Now, medical error. You make a mistake. Is likely to cause a great deal of cognitive dissonance and a threat to identity. Research on clinicians who make errors has referred to clinicians in this situation as the second victim, because the research shows tremendous psychological harm that can result from making an error. That it can lead to, almost post-traumatic stress disorder types of symptoms. I mean, I don't need to tell you, you can talk to a lot of doctors and they say, the mistakes where it was clear that I harmed someone, you don't ever forget them, right? And so it's particularly, it's tough for all of us at any stage in our career, but particularly it's an issue with junior doctors and trainees who are likely to make mistakes and haven't gotten used to it. And they're coming out of medical school where in most medical schools we've instilled this sense of perfection in them, right? So good doctors don't make mistakes when actually all doctors make mistakes. Right? So this is something that we're looking at in this study with the medical school, and so kindly was allowed to ask you guys to participate. So like I said, I had an N of 27 when I put these slides together, and I'll show you what we got so far. But first I have to tell you a concept, because the purpose of the study was to look at the effects of mindset on perceptions of error. So very quickly, I need to tell you about mindsets, and you're going to get the 2-minute version. But if you Google it under TED Talks, you can get the 30-minute version. Basically, there are two different beliefs that people tend to have about how the brain works, about how intelligence and talent work. Some people believe it's fixed. You either got it or you don't. You're smart or you're not. Or you're medium or whatever, but whatever you have is what you have and it doesn't change. It's intelligence, it stays. Right? Or you believe you get smarter at things through development, through time, through practice, and importantly, through making mistakes and learning from them. So when a fixed mindset person makes a mistake, it's much more threatening to them, because that mistake might mean that, oh my gosh, I'm not actually a person who has it, who is smart, who is bright. So you have medical school students who've been told they're brilliant and smart all their lives. They make it through medical school, so they're still being told they're smart and brilliant. And then they start doing their clinical work and they mess up. They make a mistake. Right? If they have a fixed mindset, they're likely to think this means I'm incompetent. This means they'll either blame other people and then not learn anything from the mistake, so they'll protect themselves that way. Or it'll be tremendously threatening to identity. And there's been a ton of research that shows you can measure people's mindset, whether they have a fixed or growth mindset, and it predicts all kinds of things about performance, taking on challenges, and so forth. And in studies where you have kids do a puzzle, and then you either say to the kid, I saw you do that, you did that really well. You are so smart. Or you say to the kid, I saw you do that puzzle. You were doing that really well. You put in a lot of effort. You're a kid that tries hard. Those two things, you know what it leads to? When you ask the kid, do you want to do an easier or a hard task next? The kids who've been praised for intelligence want to stick with the easy one. They don't want to take any chances. They'll be embarrassed. You'll have to take back this compliment. So they stick with the easy one. The other kids are saying, I'll do the hard one. What happens if you make them all do a hard one that they can't do, so it's frustrating, it's difficult? Then you bring them back to an easy one. The kids who were praised for intelligence do worse. These were on the initial tasks that they did. They do significantly worse than the kids who were praised for effort, who took on that hard task with more enthusiasm and were able to handle it when it was tough to do, because it's all about effort. And then this is the great part. The kids were able to tell how many puzzles they solved when they did the second easy task. The ones who were praised for their intelligence were more likely to lie about how many they had done. Right? So that's just one example. So it turns out, by the way, that telling our kids that they're wonderful at everything, they're smart, they're special, everyone gets a trophy, no one loses, there's only winners. We thought that was going to bolster their self-esteem and make them so healthy. It has made them brittle. It has made them brittle. Okay, so we could say a lot more about that, but I need to move on because I want to show you a little bit about what we saw. So that's just a summary slide of what the research has shown is the difference between having a fixed or a growth mindset. That, effort can often be seen as something for others. If you've been told that you're really bright and so forth, then you don't need to try that much. Growth mindset, people, and studies have been done with adults as well, much more willing to listen to criticism rather than defend against it. And so just a lot of differences that just this belief in whether talents and abilities and intelligence is fixed or is it malleable leads to all these different things. So in this study, the first thing I did with you was I used the 3 key measures of a fixed mindset. So you have a certain amount of intelligence and you really can't do much to change it. So there are 3 items like that, and the question was, and I don't usually like 6-point scales, but that's what these items have been studied on and the psychometrics developed on, so we use the 6-item scale. And here's what I found. So if you disagreed with those items, that's an indication of a growth mindset, and if you agreed, that was the indication of a fixed mindset. And it was kind of 50-50. Look, the mean was 3. So on average, you all were a little bit more towards the growth mindset, but it's about 50-50. When I do this with the medical students in induction week, I teach this stuff at Melbourne Medical School, the first week they're in, because they're in for a blow. They've been top of class in everything all their life, and now, except for one of them, they're not going to be top of class anymore. So we talk about this. But I often get, 2/3 or more putting up their hands as agreeing with those statements. And if you've been told all your life that you're brilliant and you're intelligent, you want to think it's a special thing, and you kind of have it or you don't, right? You don't want to necessarily think it's up for grabs, right? So that's how you all did on the mindset questions. And then I gave you a scenario, and I have to say, this was a pilot study. We're still playing around with some of these things. And this is terrible, I should say. This study is with Professor Stephen Trumbull, who's the head of the medical education department at University of Melbourne. So a junior doctor, 2 years post-graduation from medical school, was working at a nearby hospital. The junior doctor was doing a rotation in the emergency room, saw a patient who presented with symptoms that the junior doctor thought indicated a severe migraine. The patient was left unattended on a trolley for 45 minutes. It later became clear that the patient was having a stroke. The patient survived but was left with disabilities. And then you had to evaluate this incident is the fault of the junior doctor. The junior doctor should be held accountable for this. The junior doctor is incompetent. And you gave really low ratings to that, which is a nice sign. That's good. I am very interested in comparing this to other fields in medical. What did the surgeons say, do we think? And, different fields. Does everybody give those low ratings, or are you guys the really nice ones? We'll have to see. And they're correlated with each other, as you might expect. So if you think it's the fault of the doctor, then you tend to think that the doctor is incompetent. And that's kind of interesting, that correlation, because it could be the fault of the doctor, the junior doctor, but not mean that junior doctor is necessarily incompetent. But so that was interesting. Now, the next thing that we did was on another bias called anchoring. Anchoring is when an initial starting point has an undue influence on our judgment. So when we're trying to judge probabilities, what's the likelihood that this medication will be effective, or you're buying stock, what do I think the stock will be at in a year from now, or the house price will be at for a year from now. Anytime you're doing anything numerical, if you get a number in your head or someone says a number first, you will tend to not move far away enough from that number. Because you think about that number first and you come up with cognitions for why the answer is around that number. And then you no longer realize how much influence the number had. You have these cognitions that tell you that it's correct. And so what we had is, imagine you have a patient who's been experiencing symptoms of moderate depression over the previous 3 months, including sleep changes, a preponderance of negative thoughts, frequent tearfulness, irritability, and lack of appetite. No major life event or new stressors precipitated these symptoms. After careful consideration and ensuring there are no contraindications, you select a suitable antidepressant medication for the patient. Do you think that the probability that the patient will experience significant level of relief of their depressive symptoms as a result of this medication is above or below 25%? So half of you got 25%, half of you got 75%. So the question is, would you be anchored to that number? Because you're asked, please answer, is it above or below that number? And what anchoring usually does is if it's 75%, that should lead to cognitions where you're thinking about the upside of, why this medication is likely to work. 25%, you might entertain more negative thoughts about it. And then I asked you, what do you think the probability is that the patient will experience significant relief? But the other manipulation was for half of you, it was your patient, and for half of you, it was some other doctor's patient, okay? And because one thing I've always been interested in is, do you have more anchoring when the anchor is something you'd like to confirm? So if the anchor fits with how you'd like to see things, do we get a stronger anchoring bias? And I've always wanted to test that. So this is the first time we've done it. And we're picking up something here. So we thought there would be an anchoring effect. We thought people might give a higher chance that their own patient will get better than some random other guy's patient. And we thought that there might be an interaction with those two. And remember, it's only 27. We're talking about 4 groups, 4 experimental conditions. So this is, very, very early days. But we're starting to see a little something. There was a marginally significant effect for the anchoring. So if we just take the average of the 25% anchor people and the average of those of you who got 75%, you give a higher probability if it's 75% than 25% at a marginally significant level, again, with a very small sample so far. But the other thing that happens is you move away from that anchor significantly more, the low anchor. You move away from it significantly more. But actually, I should strike the word significant. There's a tendency to move away from the low anchor when it's your own patient. So when it's somebody else's patient in a high anchor, that's good. You guys were nice. You were like, yeah, I want that patient to get better too. Right? We're gonna vote on that one. That's good. That means you guys aren't jerks. That's very good. But what does seem to happen is that when it's our own patient and we get this low probability to think about the patient getting better, we don't seem to be as anchored to that number. We tend to move away from it. So I'm very, very excited to see as we move into the bigger stage of the research. And we will send you, we'll send you out, or I'll come back to some other talk sometime and show you the big study when we get it all done to see if that holds up as we get more data. And then just finishing up here, errors in diagnosis relative to others. There's a tendency for us to think we make fewer errors than our peers, but not much. We were pretty equal. Most of you said, I think I'm going to make pretty much the same as my peers do. Same thing in errors in treatment. Though, for both of those questions, it was predicted by a fixed mindset. So those with a fixed mindset thought they made fewer errors than those with a growth mindset, which was interesting. Now, maybe they do. We'll have to somehow control for that. But at least their perception is that they're making fewer errors. And then, how worried are you guys about errors? And you're somewhat worried. So a few of you said, compared to other doctors in my area, I don't think I'm very worried. Some of you said about the same, but most of you were above, thought you worry more. Well, about half of you thought you worry more than others, which again, may be somewhat, but if you all worried the right amount, we would have an even distribution, right? So there seems to be a bit of worry. And then how often do you worry about making an error? Again, so this was the middle of the scale sometimes, and most of you were at the higher end of the scale, although most of you were not at the extremely high end of the scale. But that's kind of telling me that being interested in how doctors worry about errors is maybe an interesting area for us to do research on and an area for potential good. If everyone had said, no, I never think about that, then we might think, well, either you're being very defensive or it's just not a problem. But it does seem, and if I were making the kinds of decisions that you guys were making, I'd be pretty I would worry sometimes too. I mean, it's very tough what you're having to do. And that's one thing that's amazed me sort of going from the business school where if they screw up, their company loses money, but it's not the end of the world, right? And then to the medical school where these young people are being asked to make life or death decisions at a time when they still feel very far away from being equipped to do so, that it's not surprising that a lot of them run into trouble and maybe need some help. And so the very last thing, and I know you're ready for me to get the hell out of here.
No question. It was more about questions.
Oh, for questions. Okay. So just really quick, how do you change mindsets? A fixed mindset isn't fixed. So if you were one of those way on the high end of the scale and you're thinking, oh, well, maybe it would be better to have a little bit of a growth mindset. Here's the key thing. And again, you can look at the slides. Go on TED Talks, put in mindset. You'll get 2 beautiful talks from people about this. But the key thing to do is listen for your fixed mindset voice. We talk ourselves through things. If you're a cognitive behavioral therapist, I don't need to tell you, that talk ends up being really important in terms of our emotional responses to things. So this is a particular type of talk to listen to, and something you can listen to in your patients, which is, when they're facing a challenge or facing a setback or they've heard criticism, are they saying fixed mindset things to themselves? What if I fail, I'll be a failure. I knew it was a risk. Now I've shown the world how limited I am. This criticism means I thought you were capable, but now I see you're not. Those are all things you would say to yourself if you think it's all about you have it or you don't, right? And these things suggest that maybe I don't. Realize that you can decide how to interpret things. Again, those of you who do CBT, that's what you're spending day in and day out with your patients convincing them of, is that they have some choice over how they interpret things. You can interpret setbacks as signs that your fixed talents and abilities are lacking, or that you need to stretch and grow. You have that choice. And then when you hear the fixed mindset, speak back with a growth mindset voice. The idea being that over time, that will start becoming the default voice. That will start becoming the new habit. What if I fail? I'd be a failure. Most successful people have had failures along the way. It wasn't my fault. If I don't take responsibility, I won't ever learn. So that's sort of the process for getting more of a growth mindset. I do a lot of teaching resilience, and research that's coming out now is suggesting that a great way to make people more resilient, in addition, teaching them the tools and all that stuff of resilience is great, and I spend a lot of time doing that. But if you can just move them a bit from being a fixed mindset to a growth mindset, you can move them in that direction, maybe a standard deviation, that's a great lever to pull to make people more resilient. Because if they have a growth mindset and then they encounter adverse events, they're likely to make healthier attributions, healthier meanings, and come up with better coping strategies. Okay? And so that's it. And now let's have some questions.
Great. Thank you, Jill. Thanks for the brilliant presentation.
Thank you.